Welcome to our 9th video in Rapid Interpretation of ECG series. In our 6th video, we discussed how electrical current travels from the SA node to the AV node, where it pauses for a fraction of a second. This delay at the AV node is represented by the PR interval on an electrocardiogram, ECG. The normal PR interval is between 0.12 and 0.20 seconds, which equals 3 to 5 small boxes on the ECG. The PR segment is the flat portion of the ECG that represents the AV nodal delay. Now, let's discuss heart blocks, which occur when there is a delay or blockage in the electrical conduction, mostly at the AV node. First-degree heart block. The impulse is delayed but still conducted to the ventricles. The PR interval is prolonged, meaning it is greater than 0.20 seconds, but it remains constant across the ECG. Every P wave is followed by a QRS complex, meaning there are no dropped beats. This condition is usually benign and does not require treatment. This type of block is usually benign and may be seen in athletes or during sleep. Second-degree heart block. In this condition, some electrical impulses fail to conduct, causing missing QRS complexes. There are two types. Type 1, also called Mobitz type 1 or Wenke-Buck. The PR interval gradually increases with each heartbeat until an impulse fails to conduct, leading to a dropped QRS complex. This occurs because the AV node becomes fatigued and eventually fails to transmit the impulse. The pattern repeats, usually in a fixed cycle. The ratio of P waves to QRS complexes is not equal. For example, there may be 3 P waves for every 2 QRS complexes. Type 2, which is also known as Mobitz type 2. In this type, the PR interval remains constant for conducted beats, but some QRS complexes are suddenly dropped without any warning. The block occurs below the AV node, usually in the His-Purkinje system, making it more dangerous. The P waves and QRS complexes follow a fixed ratio, such as 2 P waves for every 1 QRS complex or 3 P waves for every 1 QRS complex. This condition can progress to complete heart block, so it often requires a pacemaker. Third-degree heart block, complete heart block. In this severe condition, no electrical impulses from the atria reach the ventricles. The atria and ventricles beat independently, which is called AV dissociation. Since the ventricles do not receive impulses from the SA node, they generate their own rhythm using a secondary pacemaker located below the AV node. This secondary pacemaker could be the AV junction, producing a heart rate of 40 to 60 beats per minute with a narrow QRS complex. The ventricles, producing a much slower heart rate of less than 40 beats per minute with a wide QRS complex. Because the ventricular rate is too slow to sustain proper blood circulation, this condition is a medical emergency and requires an immediate pacemaker.